ocular injuries, lessons to be learned. And I am Dr. Devesh Kumawat, the Chief Instructor. And with me here on the dais are Dr. Saranya Devi and Dr. Ashish Markhan, who are there as the co-instructors. So ocular injury is an important arena which every ophthalmologist should be well versed with. And this instruction course will help you identify and manage the common ocular injuries appropriately. So without any much waiting, I'll invite our first co-instructor, our first speaker, Dr. Ashish Markan. And Ashish Markan has done his post-graduation at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIMS, New Delhi. And he did his MCH in Vitreoretina at PGI Chandigarh. And currently he is working as a consultant Vitreoretina at I7 Hospitals, New Delhi. And he'll be speaking on introduction. He'll be giving us a brief introduction to ocular injuries. So over to you, Dr. Ashish.
Thank you, Dr. Devesh. A very good morning to all. So today I'll be talking about ocular trauma, just a basic introduction. So you know that ocular trauma is one of the leading causes for reversible as well as irreversible loss of visual function. It is important to promptly recognize, evaluate and manage ocular trauma. So when we look at ocular trauma, there are various aspects where the injury can happen. It can either be globe injury, could be optic nerve head injury, or it could be an adnexal injury. So ocular injuries are basically classified broadly into two categories, mechanical or non-mechanical. Mechanical can then further be classified as globe injuries or adnexal injuries, and non-mechanical into chemical, thermal, electrical or radiation-induced injuries. So when we talk about the setting of injury, like the patients who commonly present to us in the OPD, the most common site of injury are either during the daily activities, road traffic accidents, sports injury, assault, agricultural activities, or industrial work-based activities. So it was very important to actually classify these ocular injuries and give them a terminology. So it was in 1996 that Birmingham Eye Trauma Terminology System, which is shortly known as BETS classification, was introduced. And according to that, eye wall is defined as sclera as well as cornea. And the closed globe injury is when there is a partial thickness injury to the eye wall, and open globe injury is when there is a full thickness injury to the eye wall. So closed globe injury can further be divided into contusion and lamellar laceration, whereas open globe injury can be divided into rupture, laceration. And then laceration can further be divided into penetrating injuries, perforating injuries, and intraocular foreign bodies. Rupture is a full thickness wound of the eyeball which is caused by a blunt object and is due to an inside-out force. Usually happens at weak areas of the eyeball. Laceration is a full thickness wound of the eyeball which is due to the sharp object and is an outside-in force. Penetrating injury is a single entrance wound due to a sharp object. Intraocular foreign body is when there is an intraocular foreign body inside the eye, either in the anterior segment or in the posterior segment or impacted in the retina. And a perforating injury has a separate entry and an exit wound. The injury is caused by a sharp object. So now, once we have learned about the terminology or the basic nomenclature, now it is important to classify ocular trauma. It is done on basis of the type of injury, the grade of visual acuity, depending upon the pupillary status, whether RAPD is present or is absent, and about the zone of injury. Amongst these, grade and pupillary reactions are the most important prognostic factors. So when we talk about closed globe injuries, so type of injuries, either it could be a contusion, type A, type B is lamellar laceration, type C is superficial foreign body, and type D is mixed. Talking about the zone of injury, which is very important, zone 1 is when the injury is happening just in the bulbar conjunctiva, sclera or cornea. Zone 2 is when it involves the anterior segment or the pars pliccata, and zone 3 is when the posterior segment is involved. Then we also look at the pupillary reactions and grade the visual acuity. Similarly, when we do classification for the open globe injury, there are again 5 types of open globe injuries. Type A is rupture, type B is penetrating injuries, type C is intraocular foreign bodies, type D is perforating injuries, and type E is mixed. Talking about the zone of injuries, it could either be zone 1, which involves cornea and limbus, zone 2, which involves limbus to 5 millimeters posterior to the sclera. This 5 millimeter figure is very important because after this the aura starts, and anything which causes injury in the zone 3 likely to cause injury to the retinal structures. So zone 3 is posterior to 5 millimeters from the limbus. Then we again grade it similarly as per visual acuity and whether the pupillary reaction RAPD is present or is absent. Now also it is important to prognosticate a case. So it is done on basis of various variables. It could either be functional variables or anatomical variables. Functional variables is an initial visual acuity, and anatomical include whether there is rupture, endophthalmitis, perforating injury, retinal detachment, or presence of afferent pupillary defect. So all of these variables have been given some score, and the visual acuity, better the visual acuity, better the score, and then either of these is present if globe rupture, endophthalmitis, perforating injuries, retinal detachment, RAPD, they are given a negative score. At the end, and we compute the entire score and we give a raw sum score, and depending upon that you can actually estimate the final visual outcomes. Now what is the mechanism of closed globe injuries? So it is basically based on coup counter coup injury. Coup injury means that the impact is happening at just at the site of impact, or the injury is happening at the site of impact, and counter coup is basically it happens directly opposite to the side where the impact has happened, and it is due to the shock waves which are traveling from the site of impact to the posterior pole. So there is actually a decompression, and then the globe, there is a compression and there is a decompression. During the decompression, the globe rebounds more than its normal shape and can cause various contusion injuries inside the eye. So some of them are like subconjunctival hemorrhage, hyphema, angle recession, iridodialysis, cyclodialysis, sphincter tear, rosette cataract, zonular dialysis, retinal dialysis, Berlin's edema, vitreous hemorrhage. So this is very important when we talk about rings of trauma. So 7 rings of trauma are actually circumferentially oriented ocular structures anterior to the equator, which are classically damaged following a closed globe injury due to coup contra coup injury. And these are, we have already discussed them. So these are sphincter tears, iridodialysis, angle recession, cyclodialysis, clefts, trabecular meshwork tears, zonular dialysis leading to lens subluxations, and retinal dialysis ultimately leading to retinal detachments. Lamellar lacerations, we have already told that they are superficial injuries due to sharp object, but we need to do a Siddle's test to rule out any full thickness defects. Superficial foreign bodies are the foreign bodies which are lodged just on the ocular surface or in the fornix or the bulbar conjunctivas. Rupture is an inside-out force due to a blunt object. The most common locations are the weak locations like limbus, previous surgical wounds, or physiological scleral thinning parallel to or underneath the insertion of the recti muscles. So either the rupture could be overt. You can actually see there's a rupture, there's a prolapse of the intraocular tissues. But there are cases where there is an occult rupture, and it is very important in an emergency to basically rule out and look for the signs of occult rupture, which are either the conjunctiva is very boggy or chymosed. There could be subluxation of the lens in the subconjunctival space. IOP could be low. The pupil could be centric or peaking. And there could be vitreous hemorrhage or vitreous strands pointing to ocular coats, basically suggestive of vitreous incarceration. So penetrating injuries are further, it could either be corneoscleral without any prolapse, it could be scleral without any prolapse, then it could be a corneal laceration with iris prolapse, or it could be a scleral laceration with a ciliary or vitreous prolapse. So intraocular foreign bodies, they could be either reactive or non-reactive. So further they are divided as metallic, non-metallic, and metallic are iron, copper, which are more commonly seen and could lead to sidrosis. So it is also important to rule out occult intraocular foreign bodies and actually look at the signs of occult intraocular foreign bodies. These could be iris holes. There could be signs of toxicity like sidrosis. You can actually see brownish discoloration of the lens, of the cornea, etc. So lastly, as we already discussed, perforating injuries are when there is both entrance and the exit wound, and the exit wound usually closes by fibrosis within 5 to 7 days. So to summarize, ocular trauma is an important cause of blindness. Proper terminology and classification system should be followed for uniform nomenclature and accurate transmission of data. Open and closed globe injuries have different pathomechanics, and prompt recognition and early intervention limits the ocular morbidity. Thank you.
So, thank you, Dr. Ashish. You have given a wonderful overview of the terminology system as well as the Ocular Trauma Society scoring system, which is important for prognostication of ocular injuries. And you have very well highlighted the importance of identifying the subtle signs which are suggestive of occult rupture or occult open globe injuries. So if there are any questions from the delegates they want to ask, or if there are suggestions from other panelists.
I would I have not highlighted that point, but I would just suggest that whenever you find a patient of ocular trauma in your emergency, it is always important to get an X-ray orbit. even if it is an open globe injury or a closed globe injury. So open globe injury, you'll be able to find if there's an intraocular foreign body, and if it is a closed globe injury, so you'll be able to rule out whether there is some bony fractures or there is some globe subluxation, which is very important to prognosticate a case and actually tell the patient before you start intervening in that case.
So yes, other than the orbital fractures, sometimes the open globe injuries may be self-sealed, and the point of entry may not be appreciated on slit lamp examination also. So there can be intraocular foreign bodies which may be missed and which could lead to problems in the future. And she is currently working as a consultant pediatric ophthalmology, strabismus and neuro-ophthalmology at Dr. Agarwal Eye Hospital, Chennai. And she'll be telling us the tips and tricks to win the real battle of open globe injuries.
Thank you, Dr. Devesh, for a kind introduction and for giving me this opportunity. So I'll be talking on open globe injury, the real battlefield. Trauma terminology has already been discussed in detail by Dr. Ashish Markan, and this was again discussed, so I will not repeat it. So how to go about initial evaluation? First of all, we have to assess if the patient has any life-threatening injuries, because we should always remember to see the patient as a whole, not just the eyes. So life over eyes, and then if there is any life-threatening injuries, we have to immediately refer the patient to trauma center and then deal with ocular injuries later on. And if we know there is only ocular injury, then we have to go ahead and do the first aid for the eyes. Minimize the manipulation of the tissues as much as possible before taking the patient into the OT, and apply eye shield where and if possible, and confirm the tetanus immunization and systemic analgesics and antibiotics to prevent further occurrence of endophthalmitis. So how to go about ocular assessment? We have to take a thorough history as to whether any exposure to metallic foreign bodies and what was the nature of the injury. All that has to be taken care in the history, and we have to go ahead with the external examination. Look for facial symmetry or any bony discontinuity to rule out the orbital fractures, and visual acuity and pupillary examination is important, which was highlighted by my previous speaker already. So this is a comprehensive workup. Like, we have to look at each layer of the eye before proceeding with the further management, whether there is chemosis, hemorrhage or foreign body in the conjunctiva. In the subconjunctival space, phacocyl was shown by Dr. Ashish. It was a nice picture. And in cornea, we have to rule out any foreign body, laceration or tissue loss. Sclera, we have to look for laceration, melt and occult rupture. In case of anterior chamber, we have to look for cells, flare, fibrin, foreign body, hypopyon or hyphema. In case of iris, we have to see for iridodalysis, sphincter tear or iris holes. These iris holes would indicate the presence of intraocular foreign body again. In lens, we have to look for if there is any subluxation, cataract, capsular rupture or foreign body, which would guide us towards a further management. In case of posterior segment, we have to look for any endophthalmitis, intraocular foreign body or retinal detachment. And investigations, apart from routine hematological investigations required for anesthesia clearance, we had to do X-ray, orbit and AP and lateral view to rule out of any fractures of foreign body. CT orbit is considered to be the gold standard investigation. If at all, if we are doing ultrasound, we have to do it with extreme caution to avoid further tissue loss. And the goals of management are, we have to maintain a watertight globe at the end of the procedure, and we have to remove any non-viable tissue and foreign body, reposit whatever viable tissue you see if and when possible, and avoid any iatrogenic damage, and restore visual function if possible. So these should be the goals of management. And the choice of anesthesia should be general anesthesia, because apart from anesthesia and akinesia, it also reduces the intraocular and intraorbital pressure. If you see the laceration is only small or only anterior, then we can go ahead with topical or local anesthesia. Apart from that, ocular triage, that is, we have to first repair the globe and then go ahead with adnexal injury, because repair of adnexal injury would cause pressure on the globe. So how to approach? First of all, we have to go ahead with gentle irrigation whenever we see open globe. Perpendicular irrigation forcefully should be avoided to avoid further tissue loss. And if we are suspecting an occult rupture or if we are suspecting scleral perforation, we have to do 360-degree peritomy. And if needed, even the rectus muscles have to be disinserted, and the sclera beneath it has to be looked upon carefully to avoid any unattended scleral perforations. And we should remember to use spatulated needles, not the cutting ones. And non-absorbable sutures should be used for the cornea. We'll discuss about the suture technique in detail in the next few slides, and absorbable suture can be used for cornea. There was this recent study which was done by a recent article by Zhou et al. And here they have explained in few pictures how to repair open globe injuries. Here you can see this is a corneoscleral laceration. We should always do limbus repair first and then go ahead with the corneal laceration and then proceed with the scleral laceration. So limbus should be repaired first. This is a point to be remembered. And in case of only corneal laceration, start from the limbus and go towards the cornea, towards the center of the cornea. As we go towards the visual axis, the suture should be shorter, deeper, and should be closely spaced. In case of limbus to limbus, first repair one side of the limbus and then proceed towards the visual axis, then repair the other side of the limbus and then proceed towards the visual axis. This is called centripetal alternating sutures. And in case of long linear scleral perforation, imagine like there are two halves of the wound. First put the first suture in the middle of the wound and then go ahead on each halves. This is called sequential bisecting sutures. And in case of complex lacerations like this, first we should repair the linear lacerations, and at the end we should come to the intersection. We should always close the intersection at last, either with purse ring or mattress suture. And in case of very posterior sutures, do not try to repair as much as possible. Just go from anterior to posterior. We have to keep dragging the anterior sutures and go towards the posterior end only till the visibility is there. And these are the pictures which show how to suture. Like the sutures have to be perpendicular, and we should make sure that the zones overlap. There should not be any gap between the sutures, and we should tighten to oppose the wound properly, and it should be equidistant on either side of the wound. In case of oblique wound, always place a longer suture, and it should be partial thickness. 90 to 95% depth should only be placed. It should not be full thickness. And bury the knot always away from the visual axis. And in case of tissue loss, always replace the tissue. Do not pull and close the tissue. In case of prolapsed iris, what to do? We have to look for the viability, not just the time of wound. 24 to 36 hours maximum is a safe period. If it is visibly infective, do not reposit. If necrotic, do not reposit. And if there is iris prolapse, always abscise, do not excise. Management of lens matter. In case of disrupted lens capsule, if you visibly see lens matter in the anterior chamber, or if vitreous is involved, that is when we have to go ahead and do lensectomy. In other cases, we should wait and plan for second stage procedure only. In case of corneal perforations, we can either, if it is a small perforation, we can apply cyanoacrylate glue with BCL, or amniotic membrane graft can be done. In case of limbal involvement, we can go ahead with Gunderson's flap and patch graft. If you see a definitive tissue loss, we should always plan for patch graft or PK. So in case of full thickness corneal laceration, if it is just simple, go ahead with sutures. Uveal laceration, abscise or reposit depending on the viability. In case of lens involvement, do lensectomy. If there is vitreous involvement, vitrectomy has to be planned. And scleral involvement, put scleral sutures. If there is tissue loss, remember to replace it with a graft. So this is a case of traumatic limbal perforation with an iris prolapse where there was tissue loss. So I went ahead and did a corneal patch graft. And this is another picture which was sent by Dr. Jayanand. Here you can see he did not touch the lens because there was no rupture of anterior capsule. So remember that lens can be dealt later to give better visual results. So postoperative management is also equally important. Apply patch, topical corticosteroids, antibiotics, cycloplegics, and suture removal should be placed. And remember to do second stage surgeries with your colleagues. Either we'll have to involve the vitreoretinal colleagues later on. So thank you for the opportunity.
Thank you, Dr. Saranya, for the wonderful presentation. So I have a few questions that I'll be asking. So what is the role of preoperative antibiotics, topical antibiotics? Do you think they are justified in an open globe injury? Should we be giving, because they could be toxic, the preservatives could be toxic to the intraocular contents? Is it so, or?
The recommended thing is systemic antibiotics have to be started to prevent the endophthalmitis. So if we are planning, of course, we'll be planning emergency surgery, so we can postpone using the topical antibiotics in case of open globe injuries.
As she has rightly highlighted that necrotic tissue should be abscised and should not be reposited. So could you tell, for the benefit of the house, that why, how can you make out whether the tissue is necrotic or viable? So
first we have to take the history and how long has it been since the injury, and if we look at the tissues, if it is obviously necrotic, if there is a membrane over it, and once you touch it, the necrotic tissue will with your forceps itself. You'll not be able to repose it no matter how much ever you try. In that case, we should not pull and cause further damage to the necrotic tissue. We should rather abscess in flush with the wound to avoid any further damage to the rest of the tissue available.
So, are there any questions from the delegates or from suggestions from the panelists?
A very nice presentation, Dr. Saranya. One point which I feel, once the open globe injury has been repaired, it is very important to look for the signs of endophthalmitis for next 2 to 3 weeks. And like we see our residents, sometimes they miss these signs, and it is very important to actually look at the subtle signs of endophthalmitis, do a very gentle ultrasound after the repair has been done. And I think then the visual prognosis becomes much better if intervention is done at earliest.
Thank you, Dr. Saranya. So, I invite our next speaker, Dr. Diksha Rani. And Dr. Diksha has done her post-graduation and she is currently doing her senior residency in pediatric cataract, refractive and retina services at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIIMS, New Delhi. And she'll be telling us when and how to intervene in patients with post-traumatic cataracts.
Good morning, everyone. Thank you for this opportunity. I'll be discussing on traumatic cataract and when and how to intervene. So as it has been discussed in the previous talks, the various mechanisms, the equatorial expansion or the coupe and contour coupe injuries can damage the zonule and the lens itself, leading to varying presentations of traumatic cataract. There can be alteration in transparency, position or volume of the lens, and all this can occur alone or in combination and can give us various presentations. So again, a detailed clinical evaluation, as has been already discussed, should be done. These are the certain clinical pictures in open globe injury. Here we can see there is a full thickness corneal laceration along with a synechia and a total cataract. Another picture where there is partially absorbed cataract and there is a repaired corneal perforation can be seen. Other pictures with repaired corneal perf with total cataract. Sometimes the open globe injury can manifest with a rupture of anterior capsule and flocculent cortical matter can come in the anterior chamber. This is another case where there is a full thickness corneal laceration causing anterior capsular rupture, but the central visual axis is spared. In closed globe trauma, the most classical finding is rosette cataract. And early rosette is when fine fluid droplets are arranged between the radiating lens fibers just beneath the capsule. Whereas the same opacified particles, when they get impacted deeply within the suture layers, they become the late rosette cataracts. These are most commonly seen but not always seen. So here you can see the early and the late rosette cataracts. These are not always visually significant. Like in this case, if the visual acuity is good, we can always wait for the surgery. But it's not always rosette. We can have other presentations. Like in the first one, there was a closed globe injury. The patient presented with hyphema. And after hyphema drainage, we can see there is a partially absorbed cataract and iridodialysis. Another picture again showing anterior capsule rupture with the iridodialysis. Besides that, we can have subluxation with varying degrees of vitreous in the anterior chamber. We also can have a loss of volume, as we can see in this picture, both are partially absorbed cataracts, or we can have intumescent cataracts where there is a gain of volume. Ultrasound biomicroscopy is an important investigation which helps us to understand what is behind the iris and behind the cataractous lens, which often cannot be seen on AIOCT as well. So next is when to intervene. If visual acuity is good, we always observe for the progression of symptoms, manage IOP and intraocular inflammation. Repair of the open globe injury, of course, is must and the emergency procedure. If there are some focal opacities outside the visual axis glare or monoocular diplopia, the trial of miotics can be given. And in case of subluxation, there can be introduction of new cylinders, and hence refraction and glasses are often helpful. And if there's a corneal scar, we should always give a contact lens trial first before proceeding for the surgery. And when do we intervene in all cases of visually significant cataract? If there is lens-induced glaucoma, there's capsular rupture leading to flocculent matter in the anterior chamber, and as a preparatory thing for the posterior segment evaluation. But before going, always explain the prognosis, as the prognosis is always guarded. You can have surprises on table as well as post-operatively, and hence you should always have a plan B. Always your CTR, CTS, prolines, and your iris claw or SFL things should be ready. So here I'll be discussing few cases. Now this is the first case where we can see there is a full thickness corneal laceration. The child had an injury with thorn. The thorn went through the cornea, through the iris, through the anterior lens capsule, causing total white cataract. So this was an intumescent lens, and hence a double rhexis technique was used. A small rhexis was made, the lens was decompressed, and then the rhexis was enlarged. In this case, again, after explaining the prognosis, we still expected that the prognosis would be good, and as the degree of damage was not much. So we had planned a multifocal IOL in this patient, as the pre-op keratometry and excellence could also be captured well. Again, with a backup 3-piece. There was a membrane on the posterior capsule which was removed with the forceps. Intraoperatively, again, we saw the fundus which was normal. There were no signs of choroidal rupture at the macula. And we went ahead with the insertion of a multifocal IOL, and next post-op the patient was 6/6 and N6, and the child was happy. Another patient with the partially absorbed cataract, here we can see that there is an anterior capsular plaque with the posterior synechiae. The synechiae has been released. Using capsule and forceps, the anterior capsular plaque is being removed. Very carefully, the lens matter between anterior and posterior capsule should be aspirated bimanually. And we have got a clear visual axis. Now this child was around 3 years old, so a posterior capsular exit with anterior vitrectomy was also planned. And a 3-piece IOL was placed in the sulcus with optic capture. So optic can be captured, and we can see a stable IOL with a clear visual axis. Now this is an adult patient with more than 9 clock hours subluxation. We should always remember that the evaluation of subluxation on slit lamp is always deceptive. On table, we always find that the subluxation is actually more what it actually seemed. So very careful. Rexes, I always prefer forceps for rexes in cases of subluxation so that you minimize the damage to the zonules. Capsular hooks can be placed. In this case, we had to place multiple capsular hooks. But however, during surgery, we could not salvage the bag because there was an anterior capsular nick, and we actually then went ahead with anterior vitrectomy and SFI. Another patient in which the bag could be salvaged, the bag was fixated with a Sioni ring. So the Sioni ring has been threaded, and a flap was created at the site of maximum subluxation. And using railroading technique, the Sioni implantation has been done. So both the ends of the straight needle 90 proline are docked in, and the Sioni can then be inserted in the place, and the suture is tied after bringing the modified CTA to the desired position. This is a case when there was more than 9 clock hours subluxation and a hard cataract. We did not even attempt a bag fixation, but directly an intracapsular cataract extraction was planned, and this was followed by insertion of good anterior vitrectomy, and retrofixated iris claw was done for visual rehabilitation. And sometimes there are cases when there is posterior subluxation of lens. This topic will be dealt by Dr. Devesh. I'll just give a small glimpse that this is a patient who had post-traumatic dislocated lens. Scleral flaps were created. This was followed by a good pars plana vitrectomy. And phaco-fragmentation was done to remove the nuclear matter in the vitreous cavity. And this was followed by insertion of indentation was done to look for any breaks or dialysis which could be managed. And at the end, a scleral fixated IOL was done to attain optical rehabilitation. So in the end, I would like to summarize that in cases of traumatic cataract, the communication is always difficult, but it has to be done properly. And after that, give your best so that you can give optimal outcomes for yourself and the patient. Thank you.
Thank you, Dr. Diksha, for the wonderful presentation and excellent videos you have shown. So are there any questions from the, yes, please. So Dr. Diksha, would you like to answer?
Suture removal, ma'am, for open globe injuries you asked, yeah. Usually 3 to 4 weeks, we can begin with alternate suture removal and the AC remains formed. It can be completed on further follow-up. If the wound is long, alternate suture removal can be done at around 3 weeks.
And usually they take GA, no?
Yeah, if it's GA, that may vary. If the children sometimes cooperate on slit lamp, can be done at around a month or so.
And when you said cycloplegics post-op, what is your cycloplegic for corneal tear?
So we usually give a strong cycloplegic, either hometropine or atropine. In children, we prefer atropine because that will take care of the pain as well as the inflammation. And Dr. Saranya, you would like to add something?
Yeah, in case of very small children, you're correct. Anesthesia, we can't go in and take it again and again. So we should plan for a later, like maybe around 6 to 8 weeks is the ideal thing, where we can take in for one GA setup, like one examination, and the anesthesia can also be done, and the suture removal can be done along with it. And if any second procedure has to be planned, we can look into the examination and decide for that at 6 to 8 weeks.
Thank you, Dr. Diksha. So our next presenter is, I would like to invite Dr. Gazela. Dr. Gazela Bruce, she has done her post-graduation at ESI Basai Dharapur, New Delhi, and she did her senior residency in glaucoma services at RP Center, AIMS. And she is currently working as a consultant glaucoma at LV Prasad Eye Institute, Hyderabad. And she'll be talking to us about the approach to post-traumatic glaucoma, taming the silent killer.
Good morning, everyone. Thank you, Devesh sir, for this opportunity. So, I'd like to just define this post-traumatic glaucoma. It is any post-trauma raised IOP of more than 21 mmHg, which can be acute or chronic, and after blunt or penetrating trauma, and with or without establishment of the glaucomatous optic neuropathy, and if visual field testing is possible, depending on this as well. So, of course, most data show that it is more common in males, and the incidence varies according to the study from 2.67% to 43%, and the incidence seems to be more in case of closed globe injuries, and with the increase of the years it becomes more increase in incidence. So just to know that in cases of glaucoma we will also see the signs of these 7 rings of trauma. We can see in these patients presence of sphincter tears, iridodialysis, angle recession is very important. Cyclodialysis can also be seen, which later on after closure can develop into post-traumatic glaucoma. And zonular dialysis with or without lens subluxation or dislocation, along with vitreous base avulsion and peripheral retinal dialysis. So in post-traumatic glaucoma, we have to look for all these other signs as well. So a huge list here showing the causes of early and delayed traumatic glaucoma. Early being inflammation, hyphema, lens-induced, or a massive suprachoroidal hemorrhage, whereas delayed can be angle recession, steroid response, and most importantly, all these ghost cell glaucoma, hemolytic glaucomas. It can also be divided into open angle and closed angle. Open angle being most importantly angle recession and the lens-induced, and closed angle will be pupillary block or the phacomorphic type of glaucoma. When we see such patients, we should of course do a proper examination at the first offset, even checking for the contrast and near vision. And also we should try to take slit lamp photos and fundus photos, especially in medical legal cases for documentation. So we do a gonioscopy. In cases of hyphema, this is usually delayed by 2 to 3 weeks. This is to see for presence of irregular pigmentation, any recession, pus, any cyclodialysis or intraocular foreign body. We can do an ASOCT because this is non-contact in cases of trauma to see for the AC depth, lens vault, and any occult foreign bodies. And UBM also a contact procedure which can be slightly delayed. This is to see angle recession, cyclodialysis cleft, the AC depth, and any occult foreign body. So we'll go through a few of the causes of traumatic glaucoma. One is uveitis, which will show up as normal uveitis, and management will be similar to any uveitis case. But also remember that if there is prolonged inflammation, we should evaluate for any systemic conditions or any occult intraocular foreign body. And if we use a prolonged steroid use, there might be high IOP in patients who are steroid responders. Suprachoroidal hemorrhage, of course, easy to identify from the signs with the very shallow AC and the B scan showing the suprachoroidal hemorrhage. Lenticular causes are also very important. If there is anterior dislocation of the lens, it can cause pupillary block. If there is posterior dislocation, there may be vitreous prolapse, which leads to high IOP, or there might be phacolytic or phacomorphic glaucoma. So angle recession, as we all know, it is due to tear between the longitudinal and circular fibers, and there is retro displacement of the iris root. So it has to be differentiated from cyclodialysis, as seen here, cyclodialysis on the right side. So this can be differentiated clinically or on UBM also, as we see the presence of the cleft on the right side. And also there might be features of hypotony in cases of cyclodialysis. So angle recession can occur following any sort of blunt trauma, and the reported frequency, depending on study, depends is either 20 to 94%. And after hyphema, the rate of angle recession increases, and many of these patients go on to develop glaucoma. And in some studies, it's shown that the other eye also does develop glaucoma, which shows that these patients are actually susceptible to glaucoma from the first. So 2 peaks of incidence are seen. First is initially after the trauma, and also many years after the trauma, which shows that we should follow up these patients regularly. So the mechanism of trauma is similar for both angle recession and hyphema. Because of the contusional deformity, this leads to shearing forces at the angle, leading to the separation of the fibers. So what are the factors which predict the development of angle recession glaucoma? The poor initial visual acuity after the trauma, higher age, and lens injury and hyphema. So how do we manage? Just like open angle glaucoma only, we have to do meticulous follow-up, treat medically, and if not treated medically, we have to go for surgical procedures, starting from filtering surgeries, implants, to finally cyclodestructive procedures. Hyphema, the mechanism similar to angle recession, and these are the blood vessels which are commonly involved in the bleeding during the hyphema. So how does glaucoma occur in hyphema? It can be due to occlusion of the tubercular meshwork by any clot, inflammatory cells, or RBCs, or if the clot is very large, it can lead to pupillary block. So we try to grade the hyphema so that this helps us in the management of the case, whether we need to drain the hyphema or just medically manage it. So usually the grade 4 or 8 ball hyphema has to be treated with irrigation aspiration. So with this amount of hyphema, the severity of glaucoma or risk of glaucoma keeps on increasing, with 8 ball hyphema almost having 100% risk. Complications of a hyphema, if not treated properly, are it can lead to formation of peripheral anterior synechia or optic atrophy if not treated on time. And there can be corneal blood staining, rebleeding, and in children can lead to formation of amblyopia. So rebleeding is also very important, and these patients do have worse outcomes. And how do we identify it? There is an increase in the size of hyphema in the following days, or there is a layer of fresh blood over the older clot. And most people who are at risk are the ones who have any bleeding disorders. Corneal blood staining increases if the IOP is more than 25 mHg and if the number of days is increased. So we manage it by using topical steroids, cycloplegics, glaucoma medications, propped up position. And strict bed rest is only applied to patients who have a risk of bleeding. So immediate surgical management is in a patient who have sickle cell trait disease, or if the hyphema is very large with more than 24 mmHg for more than 24 hours, or if the other eye has glaucomatous optic neuropathy. So usually we can do irrigation aspiration, but usually the clots will be very large, so we have to do an anterior vitrectomy. Microhyphema is also important because even in these cases, the glaucoma incidence is similar to a gross hyphema. Ghost cell glaucoma can occur after vitreous hemorrhage 1 to 3 months. This is because the RBCs break down, and these breakdown products will block the tubercular meshwork. So how do we identify these cases? They will give a history of trauma, and there is delayed onset rise of IOP. And hemolytic glaucoma also similar. They will give a history and there will be delayed onset. So I'll just go to the last 2-3 slides. The risk factors are for development of glaucoma after trauma is advancing age, lower baseline visual acuity, higher baseline IOP, any zone 2 injuries, AC inflammation, hyphema, if there is increased pigmentation, angle recession more than 180, lens injury, vitreous hemorrhage, or any intraocular foreign body. So this flow chart is very important. As we can see here, if there is traumatic glaucoma with hyphema, we want to treat the hyphema. If the IOP is normal, we can continue with this conservative management. But if the IOP is increased, then we like to drain the hyphema, and if IOP becomes normal, we'll do conservative management. But if there is increase in IOP, we'd like to do a trabeculectomy. So in case of without hyphema, traumatic glaucoma, if the IOP and CDR is normal, we'll do a medical management, and if the IOP remains normal, we'll taper the medication over a few months. But if the IOP increases, we can either go for SLT, which is controversial, or trabeculectomy. But if there is traumatic glaucoma with increase in IOP, target IOP not being reached, then glaucomatous changes in the disc, we'd like to go for surgery. So take clinic message is that we have to diagnose traumatic glaucoma early and do a careful follow-up and more aggressively in children. But most importantly, prevention is better than cure. Thank you.
Thank you, Dr. Gazella, for the wonderful presentation and the simplified algorithm that you had shown at the end. So if there are any questions, then we can take. Otherwise, we can move to the next speaker because of the shortage of time. Any suggestions? Okay. Thank you, Dr. Gazella. So I would now invite Dr. Pranita Sahai. Okay. So can you invite me? So I think I'll present instead first, and then Dr. Pranita can take her presentation.
So now Dr. Devesh Kumawat, he has done his post-graduation and senior residency and is now working as assistant professor in vitreoretina, uvea and ROP services at Dr. Rajendra Prasad Center, AIIMS, New Delhi.
Okay. So good morning, everyone. So I'll be talking about when the posterior segment surgeon has to intervene in ocular injuries. So there are different aspects which are there pertaining to ocular injuries when a posterior segment surgeon may be called for help or rescue. Some of these may be simple injuries, while other can have grave consequences if they are not treated or detected in time. And some of these may also need a treatment with the help of your anterior segment surgeon as well. So first, this is a 26-year-old male patient who had injury to the left eye with a rubber ball, and the vision is 6/12. And you could appreciate there is retinal whitening at the posterior pole as well as in the periphery. This is commotio retinae, and it occurs because of photoreceptor outer segment disruption and RP damage. And the spontaneous visual recovery is the rule, but some residual pigment epitheliopathy remains, which can be picked up on fundus autofluorescence imaging. There is no definitive treatment. The role of steroids is controversial, and important is to differentiate the peripheral commotio retinae from retinal detachment. Now next is the choroidal rupture, which can be direct or indirect. So indirect being more common, and they are around the optic nerve head. And if they are passing through the fovea or through the papillomacular bundle area, that could lead to decrease in the vision. If it is associated with massive subretinal bleed, then one can either do a pneumatic displacement or consider subretinal surgery along with TPA injection. And one needs to follow up these patients very closely because CNVM can develop anytime later in the future at the edges of the choroidal rupture. So next patient, next example, a 41-year-old male patient, he had bullet injury to the right orbit 1 month back, and he presented with visual acuity of 660. And you can look at the temporal periphery. There is an area of chorioretinal deficiency of chorioretinal tissue, and the sclera is visible underneath. So this is chorioretinitis lopet area, and it occurs because of high-speed projectile injuries to the orbit. Now the sclera may be bare in that area, like seen in this patient, or there can be massive vitreous hemorrhage could also be there. And scarring is the rule at the margins of the chorioretinitis lopet area, and that's why retinal detachments occur very less commonly and doesn't need any treatment. Retinal breaks in ocular injuries can either occur after, can be either dialysis or contusion necrosis breaks that can occur after closed globe injury. And in open globe injury, it can occur because of vitreous traction leading to horseshoe tears. And important here is that giant retinal dialysis and tears can occur after any type of ocular injury, whether it be a closed globe or open globe. The management remains simple in the absence of retinal detachment by photocoagulation or cryotherapy. Now, macular hole is also a frequent complication that occurs after ocular trauma. And this example is of a 18-year-old male patient who had cricket ball injury, and vision in the right eye is 3/60. You can see that there is resolved Berlin edema. There is a epitheliopathy which is there around the optic nerve head, and there is a flat macular hole which is of large diameter, which is of large size. And these macular holes occur because of post-contusion necrosis or vitreofoveal traction. These holes are often, they have an irregular shape, the margins are very sharp, and there can be associated other ocular injuries that could be there, commonly being the choroidal rupture being commonly present. Spontaneous closure can occur in certain number of patients, and that can happen till 3 to 6 months of duration. And if it doesn't happen, and if your underlying RP is healthy, then you can consider for a macular hole surgery. Like vitreous hemorrhage can occur both after closed globe as well as open globe injury, and important here is to rule out any underlying posterior wound, which could be either a rupture or exit wound, and underlying retinal detachment. So ultrasound is of great boon, and you can do a gentle ultrasound in closed globe injuries and should avoid it in open globe injuries. And the management for vitreous hemorrhage more or less remains the same as it would be for the other causes, but one should keep a low threshold for early vitrectomy in open globe injuries because there could be risk of vitreous and retinal incarceration. Lens and IOL dislocation can occur after a closed globe injury to the eye. Less likely you can have isolated posterior capsular rupture wherein only the posterior capsule being thin and it gets avulsed because of the shock waves, and you can have only the posterior capsule rupture with an intact anterior capsule, and posterior dislocation of lens could also be there. And commonly these injuries are associated with angle recession and glaucoma and can have retinal breaks and retinal dialysis and retinal detachments as well. Retinal detachments, they can occur till 2 years of age and will depend on whether the vitreous is liquefied or depending on the state of the vitreous. And the retinal detachment that occur in patients with ocular injuries often have a lot of proliferative vitreoretinopathy, and in open globe injuries there could be vitreous or retinal incarceration. The management can be done with the help of scleral buckling if there are no PVR or the media is clear, and if there is a retinal dialysis, and vitrectomy is often needed if there is an open globe injury with retinal detachment. So this example, this case of a closed globe injury with multiple choroidal ruptures, and there is a large retinal dialysis which can be seen in the supranasal part managed with vitrectomy and PFCL oil exchange. Next, routine intraocular foreign bodies could be either in the vitreous cavity or they could be impacted in the ocular coats, and they could affect the vision by the ocular injury itself or due to metallosis. All reactive foreign bodies should be removed, and the timing of the foreign body removal will depend on whether what is the state of art facility available with you at that time and whether is there any endophthalmitis or retinal detachment present. So if they are present, then a primary surgery along with the primary closure should be done. Otherwise, you can delay it by 7 to 10 days and do a secondary surgery. So the surgical removal again can be done through the sclerotomy or through the limbal incision, depending on whether you are combining it with cataract surgery and depending on the shape and size of the foreign body. Now, posterior wounds can occur because of rupture or because of perforation injury, and the signs pointing it to would be presence of hypotony and vitreous hemorrhage. There will be with this case I would like to tell that how a posterior wound can be salvaged in time. So this patient had a anterior entry wound which was repaired, and there was vitreous incarceration on ultrasound, and a foreign body was there in the mid orbit. So definitely there has to be a posterior exit wound. So early vitrectomy was undertaken in such patient. After clearing the vitreous hemorrhage, the wound was seen along the inferotemporal arcade, and a chorioretinectomy was done, and silicone oil tamponade was provided. And in the post-op period, the patient's retina remained attached till 3 months of follow-up with a good vision of 6/36. Endophthalmitis can occur in 5% of the penetrating injuries, and the common organism being Streptococcus epidermidis and gram-negative organisms. A high index of suspicion need to be kept because there are other ocular injuries which are present and that could mask the presence of endophthalmitis, and management should be done with intensive systemic and topical antibiotics, and early surgical intervention is advised in cases of traumatic endophthalmitis. Last, sympathetic ophthalmia. One needs to remember that sympathetic ophthalmia, although it has decreased in the recent years, but still we see such patients, and a primary prevention can be done if evisceration or enucleation is done of the exciting eye within a few weeks' time, and systemic steroids if it's a high-risk injury. To summarize, penetrating and perforating injuries are more complex than the contusion injuries, and the results, the outcomes are often unpredictable and can be dismal. And vitrectomy should be considered early in cases of open globe injuries if there is a posterior segment abnormality, and timing is of essence. Thank you.
A very comprehensive review by Dr. Devesh. Next speaker is Dr. Pranita. She has done her post-graduation and senior residency from RP Center AIMS and is currently working as a consultant at Center for Sight. Dr. Pranita.
Thank you, Ashish, for the introduction. And sorry, I have a really bad voice, but I'll try my best to present.
Excuse me, can
Excuse
you
me, can
put
we
on the slide?
ask him not to move? Okay. Good morning, everyone. So I'll be presenting about the cornea part of chemical injuries that we deal in our daily practice in acute emergencies. So as we all know that chemical injuries account almost 10 to 20% of the patients that present to our casualties. Alkali injuries are more common compared to acid injuries, and whenever you're dealing with any patient of chemical injury, medico-legal aspect is something that you need to keep in your mind, because later on it always becomes a hassle if it is not dealt with earlier. We all know that acids do coagulate the proteins, and this limits the penetration of the acid into deeper part, while alkalis saponifies the cell membrane lipid and lead to deeper penetration and hence causes more damage compared to acid injuries. The clinical presentation can be variable. In conjunctiva, you can have chemosis, congestion, blanching, epithelial defect. In cornea, you can have epithelial defect, melting, sloughing. Also, there can be uveitis, raised intraocular pressure. The presentation may also vary based on the phase in which the patient is presented. In the immediate phase, patient presents with epithelial defect, raised IOPs. Acute phase, there is a phase of epithelial regeneration, vascularization. In grade 3, grade 4, there can be melting and ulceration. In early reparative phase, while grade 1 and grade 2 injuries show continuous healing, grade 3 and grade 4 will show corneal scarring. And in the late reparative phase, which is more than 3 weeks, grade 1 to 2 show minimal corneal changes, while grade 3 and 4 end up in corneal scarring and limbal stem cell deficiency. While assessing any patient of chemical injury, it is important to document the visual acuity, intraocular pressure, do a detailed slit lamp examination, and mention the findings on paper well for your future medical legal aspects.
Dr.
Also,
Pranita,
a double eversion of the lid.
Would you mind coming to the relevant slides,
Yeah.
because the other session speakers are there?
Looking at the doers, grading and classification, this is important to know so that we can manage the patient well. In the immediate phase, and a wash of the eye for at least 30 minutes with 1 to 3 liters of fluid. The fluid being normal saline or ringer lactate would be good, and a pH check with litmus paper is essential so that you do an adequate wash. After this, coming to the medical treatment, use of preservative-free lubricant tears in the form of CMC and hyaluronate would help. So topical ascorbate and citrate will also help in the healing, reducing the proteolytic enzymatic activity and support the collagen healing. Oral acyclovir, oral tetracycline and vitamin C is helpful. Topical steroids are essential in the early phase to reduce inflammation. Topical antibiotic encyclopedics are essential. Autologous serum and umbilical cord serum AMGs is something that can be considered on case-based scenario. Topical steroid is a double-edged sword. Sometimes in the initial 10 phase, while it is essential, later phases, if the epithelial defect is persisting, you need to stop steroid beyond 10 days. Sometimes it can also lead to development of infections in the background of chemical injury, as was seen in this case, who developed an infective keratitis, and hence steroid had to be stopped, antibiotics had to be stepped up, and steroid was reinitiated only after the infection resolved. Amniotic membranes are important where there is extensive limbal involvement. As you can see in this case, there was almost nearly 9 clock hours limbus involved, which was managed well with amniotic membrane transplants, symblepharon ring and tarso, and it healed well at 4 weeks with nearly clear cornea. Tenoplasty can also be considered in patients who have significant limbal avascularity at presentation, because tenons gives you a good vascular supply. Umbilical cord serums have a lot of epithelial regenerating property because of the growth factors it has. So to conclude, acute chemical injuries in the emergency management need to be managed with a copious wash. If it's a grade 1 and grade 2 injury, subsequent only medical treatment with topical therapy can be done. If it's a grade 3, grade 4, then you need to top up with amniotic membrane grafts, and grade 5 and grade 6 tenoplasty may be considered. However, despite of the best management, grade 5 and grade 6 do end up in a lot of complication. So these are just a few cases. Funny cases can come to you. This was a female who had applied crushed custard apple seeds in her hair for her hair treatment, ended up with epithelial defect and sloughing. It is important that you debride the sloughed epithelium before you start medical therapy. This case we have already seen. This lady had an injury with a toilet cleaning acid. Now this is an interesting case of Dhatura injury. The patient developed corneal edema and endothelitis, was well managed with only topical steroid and cycloplegic therapy. This is a case which had a grade 6 injury despite of the best management, ended up with a corneal scarring, and in such cases, surface reconstruction with limbal stem cell transplants and keratoplasty later is required for optimal treatment.
Thank you, Dr. Pranita, for the quick presentation that you covered up everything, and it was a nice presentation and nice cases as well. So are there any comments? Or so we would like to end the session, and would like to thank everyone who had come here for this interesting session on instruction course on ocular injuries. Thank you everyone. And Dr. Saranya, you would like to add something?
Yeah, in case of very small children, you're correct. Anesthesia, we can't go and